So you say, with 92 over 54, because we have that brief momentary pause there, like your mind's going to be doing at times, you're going to sit there and go, what's going on with this patient? What am I going to do with this patient? So we're thinking about, okay, got 92 over 54, what am I going to do for this person? So let's think about it. Do we know what's wrong with this person? Heart rate of 54, O2 sat of 97. But I got the blood pressure up, so that's good, correct? So let's think about it. Could this patient have been given something for pain medication? Potentially. Could you give him something for pain? Possibly, right? You gave him IV solutions. You gave him at least a liter of fluid. You're going to be transporting him at least to a level 1 or level 2 trauma center, correct? And you say, what can I give him for pain? Could you give him things such as morphine? Okay. Could you give him something such as some other type of thing other than morphine? Could you give him fentanyl or anything like that? Anything that can help reduce cardiac output, right, that may actually be able to decrease the pain but not cause him to become more hypotensive. You have to think about pain control, okay, with what you have going on. Do we have adequate cord perfusion with this patient? We have to think about those things. Do we have adequate oxygenation with this patient? Okay, could we have used atropine for the bradycardia? Is that possible? Could we have used it? Possibly. Okay, let's think about it. All right, so we now have a loss of sympathetic nervous system tone due to the neurogenic shock. But right there, we now have widespread hypoperfusion, correct? We've given them an IV solution to try to restore their blood pressure to at least 90 systolic, correct? So think about it like this. Vasopressors are very rarely, if ever, given to treat neurogenic shock, okay? Not so much spinal shock that we're dealing with, but neurogenic, okay? So when you're thinking about it, we normally would give, say, atropine 0.5 to 1 milligram per kilogram, 0.5 to 1 milligram, correct? However, it's often not done associated with this in treating the patient. Maybe if the pulse rate gets extremely slow, but it's often not done in this situation. So think about it, could you give them something for pain as well? Potentially. Could you use steroids for the spinal cord injury? Steroids are not currently recommended for this in pre-hospital, but however, when they get into the hospital, often studies have been shown that it can help for these patients, especially if they have a true spinal cord injury. So we have to think about those things, okay? And especially if there's some other kind of related problem that may be associated, caused from this, not related to the actual diving incident, but something else that may be going on. Do you have an underlying conditions such as diabetes or whatever else it may be, like we talked about earlier? So when you're thinking about it from there, think about all these variable things that you can use to treat your patient with, correct, including an opioid, including something for the slow pulse, including something for the related to the steroid. Okay, again, that's going to be up to your medical control and what they have. So again, in saying that, we talked about atropine, we talked about steroidal use, correct? So let's do what we have right here. We transported by ground ambulance to the level 1 trauma center, correct? Patient had an incomplete spinal cord injury, right? Excellent potential for neurological recovery, though. But remember what we have right here. We discharged the patient several weeks after through rehab, right? Facility, discharged home. 3 months later, almost to full mobility. So think about that. All came down to your care that you rendered to the patient, correct? Making sure that their spinal cord injury did not sustain any worse than what they had had. They did not have any type of a TBI related to it, no other type of internal injuries, just an isolated spinal cord injury that needed to take time to heal. Okay? And of course, without any further rehabilitation, the patient over time recovered back to normal. So think about this right here. Your disability assessments can help you to identify potential life-threatening problems that could be associated with this patient. Okay? That's something to think about. So always look for your life threats associated with it. The best management for this patient, of course, is what? Spinal motion restriction, making sure you're checking for any secondary injuries like we discussed before earlier in this lecture. And of course, reassessment of your interventions, and of course, in a critical nature where they're at, we're going to do a reassessment every 5 minutes. So again, let's wrap it up. Spinal motion restriction, what? Should be determined by what? The mechanism of injury, thorough patient examination, correct? Head to toe exam, caring for your patient that way, making sure you're not feeling any type associated step-offs. Knowing this patient right here suffered a spinal cord, it was actually going to be what? He actually, of course, had a in the back of his neck, he actually had a restriction that was going to be there, and through proper treatment and care and through proper rehabilitation was able to return to normal. Okay? And of course, a mobilization to focus on the injury itself. Remember this right here. Always remember, neurogenic shock should be what? Treated as appropriate to what? Maintain good perfusion to where? Right, the spinal cord. To prevent further what? Damage to where? Neurologic outcome is what we're looking for. So again, when you're looking at it, and specifically, and I'll bring it back up to here, that when you're looking at this right here, spinal shock, neurogenic shock, relatively simply the same thing. One may have permanency. The other one is temporary. So you say to yourself, what did he have? Spinal shock, neurogenic shock. Over here, this is a temporary process. This one here may actually turn out to be permanent to itself. Okay? So, and what we're thinking about what we've got, guys, I just want to make sure that everybody is clear on what we have. So I hope that y'all did enjoy this lecture. I hope that you got something out of this lecture, and y'all have a good day. Thank you.